Go on, Burma. Welcome to the Health Services Research Association of Australia and New Zealand webinar. I'm Emily, and I will be chairing the session today. As you know, the Health Services Research Association is the professional body for people doing, using, and funding health services research in Australia and New Zealand. And we have a program of events such as these that we run for everyone, as well as activities that are limited to our members. Please be sure to check out our website. But today, in our monthly webinar series, we are very excited to welcome Denise O'Connor, who is a professor and deputy director of the Wiser Healthcare Unit in the School of Public Health and Preventive Medicine at Monash University, and NHMRC Investigator Leadership Fellow. Denise comes to us today to share with us about her implementation. She won in 2023 the best paper and best implementation paper, and on the cluster randomized trial of GP feedback on musculoskeletal diagnostic imaging requests. And we are very excited to have you here with us today, Denise. If Denise will share, and if you have any questions, please feel free to use the chat function. I will be monitoring that. And at the end of the presentation, we will open the room for questions and comments and conversation. Without further ado, it's my pleasure to hand over to Denise.
Thanks so much, Emily, and thanks to the Health Services Research Association for inviting me to present this afternoon, and for those of you who are joining or those who are going to watch this at a later time. I will just share my slides. Let me know if you can see them. Can you see that okay?
Perfect.
Great, fantastic. All right, so thanks again for taking time out of your day to join today. As Emily mentioned, this is a cluster randomised trial of GP feedback that my colleagues and I conducted in collaboration with the Australian Department of Health and Aged Care a few years ago, and we had the extreme honour of being awarded the Health Services Research Association paper prizes. So thank you again, Emily and your colleagues for that. And I'd just like to acknowledge my co-authors. You can see listed on the slide. There's folk from Wiser Healthcare, and we're a national research collaboration focused on improving the value in healthcare for Australians, and also collaborating on this piece of work are folk from the Department of Health and Aged Care. I too would also like to acknowledge the traditional owners on whose land Monash University operates, and the land from where people are joining from today, and I pay my respects to their elders past, present and emerging. So diagnostic imaging for people with musculoskeletal conditions, and I'm referring to conditions such as low back, neck, shoulder, hip and knee pain, is overused in primary care in Australia and in many other parts of the world. And there are a number of evidence-based primary care guidelines now for many of these conditions that consistently recommend against diagnostic imaging in most cases, and in absence of history or features that would suggest a serious or a specific underlying cause of this pain, or unless there is unexplained symptom progression over time. And so unwarranted imaging, diagnostic imaging, doesn't help these patients, and it may cause them harm, for example, from exposing them to cumulative ionizing radiation for some tests like CT, and also from identifying incidental findings on CT or MRI or plain X-ray that can lead to a cascade of other tests and treatments, and can lead to anxiety and so forth. So this can be an opportunity cost, conducting these unnecessary diagnostic imaging tests that use up limited healthcare resources that could otherwise be directed towards evidence-based high-value care. And we also know that there's emerging evidence now that these types of diagnostic imaging tests that don't help people also contribute to carbon emissions in the environment. An example is an MRI scan that has the equivalent carbon emissions to driving a car 145 kilometres. So these are substantial implications. So today I'm talking about audit and feedback, and this is a commonly used strategy for improving professional practice, and it basically involves providing feedback to healthcare providers about their clinical performance, the care that they provide, tests and treatments that they use, with the aim of improving patient care. So interestingly, there have been now almost 300 randomised trials of audit and feedback. However, we know that the average effect of audit and feedback is modest, so it leads to about a 4% improvement in desired practice. And what we also know is that the effects of audit and feedback are highly variable across different clinical conditions, across different healthcare settings, hospitals, primary care, community care, and also the way in which the feedback is designed and delivered. There have only been 5 studies that have targeted the problem of overuse of musculoskeletal imaging in primary care. And these 5 studies have included small numbers of participants, and they've also shown mixed effects. So 3 of the trials have shown no benefit with audit and feedback, and 2 trials have shown benefit with very intensive audit and feedback interventions. So that means over a number of years providing feedback on numerous occasions to those health professionals. Or in another study, providing feedback on top of a whole host of other co-interventions like small group education, individual visiting of healthcare professionals, development and dissemination of patient education materials, and so forth. So because of these mixed effects, we don't really know the effect of audit and feedback. And so it was very opportune a few years ago that the Department of Health and Aged Care contacted Wiser Healthcare and invited us to collaborate with them to co-design and evaluate a feedback intervention to address this problem of overuse of musculoskeletal imaging. But at the same time, we collectively felt that it was also a great opportunity to basically extend or build on and advance new knowledge about how we can actually improve these types of audit and feedback interventions that so many organisations use across the world. So the aim of this study was to assess the effectiveness of audit and feedback for reducing musculoskeletal diagnostic imaging requests by Australian general practitioners, and we compared that to a no intervention control. But a secondary objective of the study was to evaluate which forms of feedback are most effective. And so we conducted an 18-month factorial cluster randomised controlled trial in general practice. And this was embedded within an ongoing quality improvement program that was delivered by the Department of Health and Aged Care. And general practices containing GPs who requested musculoskeletal imaging at much higher rates than their peers were randomised to control, no intervention, or one of 4 active feedback groups. And we used a cluster design to reduce contamination between GPs who were working within the same practice, and a factorial design to enable us to assess the effects of different factors that were hypothesised, or we hypothesised would improve the impact of the feedback. And finally, we had a no intervention control, and this was to assess the effect of any form of audit and feedback. And so the trial included GPs who were in the highest 20% of referrers overall for 11 targeted musculoskeletal imaging tests, but they also had to be in the highest 20% for at least 4 individual tests. And this was based on their requesting within the 2018 calendar year. And you can see the 11 targeted imaging tests in the box on the bottom of the slide. And we selected these as they represent commonly overused imaging tests in primary care in Australia. So we excluded GPs who hadn't made any requests for these imaging tests, or if they had less than 1,000 patient consultations in that calendar year. We also excluded those folk who had participated in user testing of the interventions with us prior to the trial, and we excluded those who were involved in a departmental compliance activity investigating their Medicare billing practices. And so we designed and then iteratively refined prototype feedback, and this explored different design and delivery elements that we hypothesized would increase the effects of audit and feedback. And these were informed by the literature, so the meta-regression in the Cochrane Audit and Feedback Review, and also various theories about how audit and feedback works. And you can see the elements illustrated in the tiles on the right-hand side of the slide. So we looked at things like frequency of feedback, and explored, recipients' perceptions of what's the ideal frequency. Would that motivate them to change or, reflect on their imaging requests? We looked at different comparators that could be used within the feedback, different sources of the feedback and which would enhance their perception of credibility of that feedback, how the data could be displayed to make it easily interpretable and to motivate change where appropriate, and also the use of co-interventions. And so we conducted user testing with 17 general practitioners on up to 3 occasions. And we asked them about the usefulness of this feedback and how acceptable it was. And then we used an iterative draft review and revise process to basically refine it over those 3 occasions. We also received input from peak medical organisations like the RACGP, AMA and ACRM on those different interventions prior to evaluation in the trial. And so apart from those two factors that we tested in the factorial design, the feedback provided to all of those 4 active intervention groups was consistent in content and length, and it comprised a 3-page individualised feedback report that went to those GPs on their musculoskeletal imaging requests, and that came from the Chief Medical Officer of Australia. It also provided them with a graphical summary it was designed to be interpretable within seconds of their overall request rate for those 11 targeted tests compared with the median rate of their GP peers. It also provided their request rates for the individual 11 tests compared with their peers. It emphasised the benefits of tackling imaging overuse that I talked about previously, and it provided links to educational resources, including evidence-based guidelines, Choosing Wisely Australia recommendations, and patient information resources. It did acknowledge that the clinical reasons for the imaging requests or their imaging requests were unknown. However, it then acknowledged and encouraged them to reflect on their use of imaging and invited them to limit their requests to situations where it would have a reasonable likelihood of changing the patient's management. And so based on that user testing and in discussion with the department about their highest priorities for evaluation in the trial, we selected these 2 factors to investigate in that factorial design. And the first one was frequency of feedback. And so we tested the effect of feedback delivered once or on 2 occasions. And the reason for this is that the meta-regression in the Cochrane Audit and Feedback Review based on hundreds of trials suggests that providing feedback more than once is associated with better effects. So we wanted to test this once versus 2 occasions in a head-to-head manner in a trial. And secondly, feedback display. So in user testing, we explored different ways of displaying the imaging feedback, and we were aiming to present it in a way that could be easily interpretable, but also that would motivate behaviour change where relevant, and also draw recipients' attention to where action may be needed. And so we decided to evaluate quite a simple design enhancement, which was highlighting those tests where they were amongst the highest requesters, really to draw their attention very rapidly to where behaviour change or further attention may be needed. So the primary outcome in the trial was the overall request rate for those 11 targeted imaging tests over 12 months. And the secondary outcomes included that overall rate of imaging requests over 2 other time points, so over 6 months and 18 months, and also the request rate for each of those 11 targeted tests over those 3 time points, so 6, 12 and 18 months. We did also look at the rate of ankle X-ray requests, and while this wasn't targeted in the feedback, we wanted to look at it as an outcome in the study because recipients may potentially switch from using ankle ultrasound to ankle X-ray. So we wanted to see if there were unintended consequences. And all of the outcomes were measured in as rate of requests per 1,000 patient consultations using MBS data, administrative data. And so this slide shows the trial design, showing that GP practices containing at least one high requesting GP were randomised either to no intervention control or one of 4 active intervention groups. And that is standard feedback display delivered once, the standard display delivered twice, or that enhanced highlighted display delivered once or enhanced delivered twice. And so this is the main part of the results. So this shows the median imaging rate per 1,000 patient consultations for GPs during the 12-month period before intervention delivery up until 18 months after. The dashed line is GPs randomised to no intervention control, and the solid line shows GPs who were randomised to one of the 4 active feedback groups. And you can see the first black arrow at the top shows when the first feedback report was sent. And as can be seen, prior to this point, imaging rates across the groups were almost identical. And then following feedback of the first feedback report, there was an initial dip and then return in imaging rates in both groups. And you can see that corresponded to roughly the Christmas period. But you'll also note that there's a marked difference between the control and intervention here, and that's showing that the feedback reduced imaging in the first few months after delivery. And then there's a substantial drop in imaging rates in both groups in March 2020, reflecting major disruptions to healthcare from COVID-19 and associated lockdowns in many jurisdictions in Australia. But that imaging picked up again about May 2020, and it fluctuated a bit over the next few months. And this was likely due to subsequent waves of COVID-19. However, throughout this time, GPs allocated to feedback had lower imaging rates compared with control. You can see that at 12 months, the second feedback report was sent to the 2 allocated intervention groups, and there was a slight additional reduction in imaging rates following this. And so we found that the feedback led to a clinically important and statistically significant reduction in overall imaging requesting over those 3 time points, 6, 12 and 18 months compared with control. And the adjusted mean difference between groups at the primary time point, so over 12 months, was 3 requests per 1,000 consultations, which represents a relative reduction of about 9%. But the relative reduction over a shorter period, so over 6 months, was slightly higher at 11%. And that you can see that in the difference between intervention and control is sort of immediately after that first feedback report. And so we estimated that feedback led to about 47,000 fewer scans over the study period. So this figure shows the median imaging rate for GPs allocated to feedback on 2 occasions, shown in dark purple, and on 1 occasion shown in light purple. And you'll notice that there was an immediate additional reduction in imaging by GPs who received a second feedback letter versus those that didn't. And this feedback shows the enhanced highlighted display. Here, it highlights to the recipient those individual tests where their request rate was higher than 80% of their peers, and that's shown in blue. And this was slightly more effective than the standard display shown in pink, particularly early on, so over the 6 and 12 months, but this small difference largely disappeared by 18 months. And so there were some limitations in the trial. So firstly, we didn't track delivery of the feedback. So we don't know if it was open and read. We also didn't look for or use alternative mailing addresses for the letters that were returned unopened. So therefore, the effect estimates that are reported here are likely to be conservative. Second, we used routinely collected MBS data to assess outcomes, and this reflects the volume of imaging requests rather than the appropriateness of requests. And you might recall that that was acknowledged in the feedback that was sent to folk. And so what this means is that high request rates may not reflect inappropriate use in all instances. And the third limitation was that during data cleaning, the department identified an error in the, basically in some of the GP addresses. And so their coding to whether they were located in metropolitan versus regional or rural areas had some problems for a proportion of the GP participants. And the reason this is important is that this variable was used as a stratification factor in the randomization. So as a result, some GPs were located within the same practice and were randomized into different intervention groups or different groups in the trial. So as a consequence, we can't exclude the possibility of cross-contamination across those groups because, you know, folk might get together, share their feedback and talk about that, and so hence have that cross-contamination. But once again, the effect estimates therefore are likely to be conservative. And we did conduct a post hoc sensitivity analysis to explore this when we identified this. And so we excluded those practices and we found that the results were very similar. And so in summary, this collaboration produced a co-design, relatively light touch feedback intervention that reduced musculoskeletal imaging requests by high requesting GPs on a national scale in the order of 11% over 6 months and 9% over 12 months. And so it was largely sustained. And so we found that feedback delivered on 2 occasions modestly improved effects over 18 months compared with one-time delivery. And a very simple modification to the way in which the feedback data was displayed, you know, highlighting those highly requested tests led to a slightly improved effects over 6 and 12 months. And so providing feedback like this to GPs who are high requesters is likely to reduce overuse, which may then translate into less potential for patient harm and reduce further low-value care. And these results are also helpful to add to that generalizable body of evidence about how to optimize these types of very commonly used interventions for improving professional practice. And only about 5% of trials currently do these sorts of, you know, built-in factorial designs or head-to-head comparisons. And I think we need more of them to basically, you know, increase the effect of these commonly used strategies. I'd like to just finish by acknowledging collaborators within the Department of Health and Aged Care, and also my colleagues in Wiser Healthcare who led this work with me, the GPs who participated in user testing of the interventions, and also the support from the Australian National Health and Medical Research Council and the department towards this piece of work. And thanks very much for listening. And I'd be pleased to answer any questions that people have.
Wonderful. Please join me in thanking Denise for your talk. This is applause in sign language for anybody wondering what the heck I'm doing. It's lovely. Really interesting piece of work, Denise. I'd like to open the floor to anyone who might want to unmute and ask a question or throw a question in the chat before I throw my questions to you. Is there anyone who has a question for Denise? Oh, yes, go for it, Lisa.
Thanks. Sorry, don't know why my camera's not working. Thanks, Denise. That was really interesting. I guess my question is, what next? What's the recommendation? Because presumably it's not only light touch, it's also very low cost, and so cost saving, really, if you've avoided 47,000 tests. I guess my immediate question is, in terms of when you were designing this with the users, what was their feel for like a postal letter versus an email, and thinking we might actually be able to, it's always a problem with feedback that we can never confirm whether they've actually read it or not. It's a problem across multiple trials. But actually, if we emailed it to them, we technically could at least see if they'd open the email. And you know, general environmentally friendly, we should probably be emailing rather than posting. But I'd be keen to see what the feedback was in the co-design around snail mail versus email. But my broader question is, what's the sort of recommendation now? Is this something that we should be rolling out anyway?
Yeah. So first of all, I mean, there were practical constraints. So the department didn't have the emails for all of those healthcare providers. So we just couldn't email. But I agree with you. And in future, I think, you know, that's likely to be more, more available. But at the time that we conducted this trial, that just wasn't a practicality. So we couldn't do it. So they routinely send out, postal paper and pencil feedback. But it's interesting, you know, folks' engagement, you know, would the engagement be the same if you received an email versus a letter? I'm not sure. Certainly, there has been one head-to-head trial of providing access to a dashboard with feedback versus a hard copy report of feedback, and that trial has shown no difference between access to a dashboard and postal feedback. And so in terms of, you know, saving the environment and, you know, all of those trees, that would suggest that might be a way to go. But yes, so we couldn't compare that in this trial. In terms of the implications, so obviously this was an effective intervention over 6 months, over 12 months. It was sustained over time, but we don't know whether that's going to be sustained in the long term or if there's going to be decay in the effects. We suspect that there would be decay without top-ups, and so we have encouraged and recommended that we should at least look at the rates over time, and that the department could consider top-ups. And then we're also interested in the application of feedback, you know, for other, healthcare practices where there is room for improvement. So I think there's lots of implications both for this, how we design feedback, how we deploy it, and its potential application to other healthcare practices.
That's great. Thank you.
Any other questions from the audience? Pauline?
Denise, that was really interesting. And my question's not really about the trial, but do you know if there's any studies about the impact of imaging on patients' preferences for treatment? This is just purely anecdotal, but people that I've known who've had an image that showed some kind of problem, which may have been, as you said, an incidental finding, seem to be much more keen on surgery. Like they think, oh, it's a physical structural problem that I need surgery to correct, and seem to be less keen on like exercises or physiotherapy or those other treatment modalities.
Yeah. I think when we have talked, so in the context of thinking about imaging in knee osteoarthritis and considering future surgery like knee arthroscopy, I think patients that we've spoken to aren't always aware of the limited benefits and potential harms of those surgical interventions. And they might be looking for a quick fix. They know the equivalent effects of, maintaining a healthy weight, and those sorts of, support from dietitians and ongoing education programs aren't supported through, MBS items. And so it is a challenge. And so I think, it's of more interest, or they might have a greater appetite for considering surgery if they hope that it might lead to better effects. So we're in another study that we're doing, we're actually assessing the effects of providing good information to consumers about the limited benefits and harms of some of these interventions. But in terms of the comparison of those that have had an image versus those that haven't, I couldn't tell you, but my hunch would be similar to yours, in that if they've seen something on an image, it's reasonable for them to consider that's the cause of the pain, which we know isn't the case. We know that we all have, the chances are lots of incidental findings if we undergo lots of imaging that haven't got a direct correlation with symptoms.
Yeah, I was just wondering, like, if that hunch is right, we might actually be underestimating the cost of the test, because it's not just the test, it's that it's then going to drive patients towards wanting much more expensive healthcare, and not effective, but expensive.
That's right. So it's not only the one-off test, but it's the cascade of subsequent tests and treatments. Indeed.
Thanks.
Wonderful. I'm curious, Denise, throw a question out myself. The design of your feedback survey and activity, what is the sustainability of, is it repeatable? Is this something that we could look at down the road and do again quite easily?
Yeah, so I mean, the intervention has been designed already, so it could be deployed by the Department of Health now. And as mentioned, it would be good to go and look at whether those effects are sustained. I suspect that they will decay over time. People are busy, they get, their focus is directed towards other things, and so hence it might creep up again over time. And so top-ups and maybe different resources, it would be good to make available resources to those folk to address knowledge or capability barriers to change. And in fact, we're testing that in another trial, which I hopefully want to present to this community in the future.
That'd be great. What I lost my question. So that's what it was. Given that the survey and feedback system is designed and is there anything that you would do differently if you could do it again?
I don't know if necessarily differently. I guess we, in that co-design and refinement process, we explored a whole host of design and delivery features that we could have tested within the trial, but this was a collaborative effort with the Department of Health, and so we worked together to see what their priorities were, and we only could test 2 factors really in the trial. I mean, you know, in a research endeavour like this, you could test 3 factors or 4 factors, but it gets very, very complicated. And in terms of deploying the trial and like implementing the trial, really, really complex, I guess. So we felt it was only, you know, feasible to test 2 factors, but there were other things that we thought would be really fascinating to test. And you saw the different tiles on that slide. You know, we explored different co-interventions, you know, looking at the credibility of the feedback and would it be perceived as more credible if it was originating from, you know, one of the peak organisations as well. Also looking at the comparator that was used. So there's a whole host of things that we could explore. So we wouldn't necessarily do the trial differently, but I think it would be interesting to look at different factors, how to make these types of interventions more useful to the folk who received that information, because we want it to be motivating. We want it to be easily interpretable. And we know that they're very busy, and so they need to have that information and not view it as punitive, but that it's actually a helpful thing to know how they're compared, you know, what their performance is compared to their peers.
Yeah, really good, really interesting piece of work. Any other questions from the room? It was all extremely clear, but very interesting work, Denise, and congratulations to you and your team in such a positive collaboration with really good outcomes.
Thank you.
Please join me again in thanking Denise for this presentation. I encourage everyone to keep watch on the website and in your emails, because next month, September, we'll have another speaker. We'll be hearing from another award winner, Karen Waller, on the residual risk of blood-borne viruses among organ donors. So keep an eye out for that. And also, it was Denise who reminded me that we have our annual conference coming up in December 4 to 6 up in Brisbane. It'll be great to see people in person if you're able to be there. Any other notes or questions? I don't want anybody to miss out. Thank you so very much for coming along. It's lovely to see everyone. And thank you, Denise, so much for your presentation. That was really interesting.
Thank you.
Yes, very much so.
Thanks, it was great. Thank you.
Thanks, everyone.
Happy week.
All the best.